I have a new toy. It's a symbol of authority, so I get to use it once a month. And only here, no place else. I'd like to welcome you. But we don't have a quorum yet. We expect to have a quorum. So we will do the agenda, but we'll do it a little out of order. Those items that don't require action until we do have a quorum. Is there any objection to altering the agenda in that fashion? Hearing none. Hearing none, it will be so done. I need to ask you this question. We now have a quorum. In accordance with State Government Ethics Act, it is the duty of every board member to avoid both conflicts of interest and appearance of conflict. Do any of you know of any conflict of interest you have with items that will be on our agenda today? Let the record show there are none. Okay, Mr. Holland.
Good afternoon.
Good afternoon.
As we do always, we'll look at the financials for Health and Human Services, and we do that by looking at DSS first. We're 58 1/3% through the fiscal year, or 7/12 of the fiscal year. So we're looking now at our at our actuals of where we are versus where we could be versus in the middle of the month. A couple of things I'd just like to point out to you is where we're over in those areas, primarily before we get up to the salaries and benefits in emergency assistance. That's because of dollars that we expend out to our providers for heating, electricity, utility assistance. Those are always higher. And our home and community care block grant, those are dollars that we front to Land of Sky Regional Council for them to administer in our aging programs. One thing I would point out to you is salary and benefits. We're a little bit higher there. As one of our commissioners, Vice Chair Belcher, had suggested before, we look to see what does that look like when we take out some one-time expenses. So we do that when we look at one-time expenses as we remove our unemployment, workers' comp, and longevity. You see those lines go down just a little bit. If you see it, you can see it go down just a little bit. And then if we look at additional one-time expense that we've had related specifically to the early retirement incentives, you'll see that further those within our budget, we're well within our budget. Those early retirement incentive costs are part of the county's plans, and you'll see that a little bit higher above our budget for a while, and then the county will cover those costs for us. So those are costs that were planned, they just are not sitting in a budgeted expenditure for us. Any questions about DSS and their expenditures? Then we'll take a look at public health. Very much the same instance where you're looking at the spending primarily as it relates to salary and fringe, that's really what's driving all of the other county units above there. So again, if we take out the one-time expenses for those workers' comp, unemployment, and longevity, you see it's down a little bit. If we go one more, you'll see with taking out the early retirement incentive costs that we're right on budget and right on track with all of the rest of the items. And the same fact happens with that in terms of covering those costs. We will work within the budget, and whatever we do, we will stay within our budget without diminishing these services. So any questions that I can answer for you related to public health? Thank you very much.
Thank you. We need to act on our minutes from January 2015. We've received those in an earlier email. Should have had time to read them. I'll entertain a motion for their approval.
Second.
Moved and seconded that the minutes will be approved as distributed. All in favor say aye.
Aye.
Opposed? Motion carries. We'll now have a presentation. One of the things that we've been doing as a board has been try to get us very familiar with everything that goes on in this county. That's possible. Because so much is going on, and we have so little time to do that. But one of the things I asked them to do is sort of to give us a snapshot of some of these priority areas. Because one of the roles that we have that we probably haven't done as much of is advocacy. And it's going to behoove us to be familiar with some of these projects and able to answer questions and advocate for them appropriately. So we have a presentation on, I believe, about 5 areas today. And I'll turn it over to our Assistant County Manager.
We do want this to be an interactive discussion, and we want to make sure that we provide you the information you need so that you can answer questions you may hear about these 3 projects in the community, and you can advocate as a board related to them. Jim and I are going to kind of tag team through the presentation, but after each one, Lisa's going to share with you some talking points you can take with you, key points, and then help us talk about what's the board's role as we move forward with these. The first is one that those of you who have been on the board for any length of time know that we've been struggling with space for some time and have twice been in front of boards of commissions, not the current board, but former boards, to move forward with space expansion at Cox, and that has been delayed, and we've found strategies to try to work around that. We're at that point again. And just want to talk about some of what's driving that, and then mostly the redesign of that space and how that space is designed to carry us into the future versus the way we delivered services when we moved into that building. You all know we are an integrated health and human services system, or consolidated, and of all the national awards we've won across programs, I think that this is one that I hold the dearest, because other counties in the nation basically said we had done as good a job or better job than any other county in the nation in figuring out how do we build a consolidated or integrated seamless system for our citizens, and that's the piece that we're most driven to do. A lot of the work we've done at Cox has been around a seamless one-door entry for our consumers where they access both all of our public health clinical services and WIC, as well as our economic services. We've really relied on automation, and I credit my leadership team, but I also credit the county manager, as we watched for early signs, even as early as 2005, that the economy was starting to change. And all economists will tell you, in Philip's world, food nutrition is the single best indicator of when an economy our United States economy is beginning to change course. We saw that as early as 2005 and began planning for that, and knew we had to invest in technology because we knew that we would be experiencing very rapid growth and changes in eligibility as a result of that. Some of the systems we purchased that you may or may not know about is QFlow. We actually did a national search for a lobby management system so that when consumers entered, we had one way to capture their data and one way to move them through our system. That is very important. I'm going to talk about in just a minute why, but I will tell you, that's one of those we went out and did a national search and found a company whose headquarters is in Asheville, North Carolina. Isn't that a great thing? They do a lot of work in embassies across the world. And they do work in DMV in some states, though not North Carolina. But what QFlow tells us is how many people enter the lobby, what they enter the lobby for, what we identify their services are available to them, how long they sit in any one single area. Also gives front desk information about wait time and how we actually can assign people to move to see a worker. So we have very detailed information about the number of people who come in that lobby, why they come in that lobby, the services they're seeking, the services they're eligible for, how long they wait in any point of the process. We can pull that data, and some of that we'll share with you in just a little bit. These are other examples of systems we put in place to try to address how we provide a seamless access for our citizens and how can we be more efficient in the space we have. We consolidated our reception and call center staff across DSS and health, and we also added lobby greeters because, and you'll see in the design of the new building, we really are moving more toward technology. We would prefer you actually sign in at a kiosk. You get entered into the system, and that the first time you're interfacing with an actual staff person is to begin gathering data. Anything you want to add on any of that?
I think what QFlow has really helped us to do also is to really minimize the time that someone waits in the lobby for services so that they're able to get where they need to go quicker and are able to be face-to-face with the direct service that they're engaging, that they came to see.
I think that's a really good point, that there's often people have the perception we serve people who don't work. The vast majority of people we serve work, and they often work in jobs where they lose money when they're not at work, and we have to get them in as quickly as we can. The other piece about that is on the public health side, we serve people who come with health issues that can create risk to other individuals. We don't want people to wait in a central lobby for a long time. We are very focused in moving people from that main lobby to the appropriate service area as quickly as we can. And you'll see when we talk about the new lobby space, it really was designed to be much more limited, and we really built out the self-serve components of that. But of the new and expanded space, less than 4% of it's dedicated to wait space or lobby space. So that's significant to know. 100,000 people a year come through Cox, and that does not include if you bring other people with you. And for any of you who may know people, I'll use the example, particularly around people who apply for Medicaid for a parent in a nursing home. There tend to be 2 people who come or 3 people who come. This is only the consumer who's seeking service. Yes?
Is it number of people served or number of people that sign in?
Well,
I mean, is that, for example, one person may make 2 or 3 visits a year?
no, it's people. People. So our strategy, as you all know, is really, and this has been as much about how do we achieve the best outcomes as well as space efficiency, is to focus on core. We have outsourced everything we're legally allowed to outsource, with the exception of Medicaid transportation, which Philip's finalizing now. We're exploring options on lab. We've explored options several times on program integrity and have not been successful. But the point about that is, if we had to bring those services back in-house that most health centers and DSS provide across the state, we'd be adding 200 more employees to that space. So that's been a very successful strategy for us. We've really tried to squeeze efficiencies out of that space, but it was designed a long time ago, and it was designed for a different business model. We always want to maximize, make sure we're using taxpayer dollars in the most responsible way. And the truth is, we're just a different system. We really are more about access through technology and about streamlining how individuals access multiple services in one portal of entry. Some of the other examples where we, primary care, clearly that was a good example of where we've outsourced, where we've increased access in the community. Realized savings we could reinvest in core public health, but some of the ones that probably don't get as much attention as file run. We've outsourced all of our file management, all of our mailroom components have all moved to electronic systems, and we've gained a lot of efficiencies through those contracts as well.
We gained a lot of space. Before we had this contract, our file room took up probably 1/3 of the whole downstairs. And so by being able to have that contract, it's really meant a huge difference in being able to have space that we have people actually directly serving patients and clients.
And this is again just with field-based staff where we can field-based staff. We've tried to make changes that allow for access to services through technology and over the phone. We built a much more stringent call service center that has a consolidated approach. We've redesigned our cubicle space, and one thing to think about cubicle space is that and I'll use Philip's Phillips staff, because they probably are the bulk of who sits in that building, who sit at a cubicle, is we've moved to a system with NCAC that requires they have scanners and 2 monitors. It's a different format. We've also become very driven by safety of staff and their ability to act, to be able to get out the door quickly if needed. I don't know if y'all remember or not, but one of our long-term care income maintenance staff 2 years ago, Lisa, was seriously injured when an adult care home resident who had just been discharged from Broughton, was not under medication, had a long history of assault on government officials, physically assaulted her in the building. We are always focused on safety and always have been around social workers who are frequently in the field and deal with threats to themselves and their families on a regular basis. Really made us look at the individuals who come into Cox and their challenges and the potential risk as well. The employee was seriously injured. As Jim said, this is a good version of our file room. Once we hired out the contracting of it, but before it all got scanned. But even moving those components out, we picked up 50 additional cubicle spaces. And those are some of the things we've done to survive over the last few years. This is, you know, people miss this. They talk about Cox as though we're planning for some large, extravagant setup for our employees. This is an example of 2 employees who sit in that environment all day trying to collect information from multiple sources and process it that close together. And that's a smaller square footage than is required for inmates in a jail. Some of the unintended consequences: moves. Health. Ellis and I heard from an employee this morning about morale issues around moves and uncertainty about where health staff will be, but they've moved 14 times in the last 5 years some elements of public health. There's cost to that. There's cost to consumers, there's cost to staff, there's cost, as you'll see on the next slide, to IT, to operations in terms of office furniture. I mean, eventually continuing to try to move as a strategy to deal with long, ongoing space needs in a mandated service is just inefficient for everybody. We're also very worried about, these are front desk staff, so this is where I walk up and talk about why I'm there today, be that related to a public health need, be that related to applying for Medicaid for my mother. This is how tight their environment is, and these are the people who sit like this, see 100,000 people face to face a year, processing that information and trying to enter it into multiple systems on dual screens. We've moved offices into conference rooms. There are no conference rooms left or meeting space left at Cox, and Phillips staff is actually training for NCAC in the kitchen.
Where does the client sit when
they're standing during that entry, when they come to the front desk.
And then there's 2 workers and 1, so that's it's not very private.
No, it's not private at all, and there's probably very few areas that have more stringent confidentiality requirements than DSS and health, or the health field, medical field as a whole. I say that's Lisa's picture of me. The other thing we've seen is caseload growth, and the part I want to point out about that, if you'll flip it, Lisa, is it's what's unusual about this is typically post-recession you begin to see those numbers decline. What we've seen and what we're seeing across the nation is people have gone back to work. They tend to have gone back to work to lower pay or less hours. And because of that, they're continuing to qualify for public assistance benefits. And at best, we're seeing a leveling, but no decline. This is important to me because people, it's easy to say we have 44,000 Medicaid recipients. What gets lost in that is that Phillips staff is processing 2,300, almost 2,400 new applications every month. It's not a stagnant number. People come on, they come off, their wages change, and they have to rework eligibility. They experience some change in eligibility. So caseload is very different than workload.
How many people would you have processing those applications? Because you look at 100 per business.
How many what?
How many staff do that processing? Are dedicated to that? Does it?
At any one time, we've just restructured. At one time, we had dedicated staff that all they did was applications, and the dedicated staff that all they did were recertifications. We're kind of in the process of restructuring to where all our staff can do both. But in the old days, we may have had 40 at the most processing, but that would have been Medicaid and food assistance.
We have about 150 IMCs. There are about 150 folks who work in there. If you try to attribute them to a caseload, which is hard, as Philip says, in the NCAC system where everybody's responsible for everybody, it can range from over 1,000 in the Medicaid transportation world to 450, 350 in other program areas. These are not people carrying light loads. That shows you the projected growth if Medicaid is expanded or when Medicaid is expanded in North Carolina. And that's important to us because that will require about 30 additional staff. We have to plan for that. And I want to make the point, federal government requires merited government employees to do this work. So this is not work we can contract out. And one of the things we've been most impacted by is under the Affordable Care Act, if somebody works for you for more than 30 hours now, we're required to offer them our health insurance. So where we have relied on temps or part-time people, we cannot do that going forward and have to plan around that. Already means we just don't have the space. We have, and I think you may see a picture of this later, we have staff in lease spaces all over town because we simply don't have enough space now. That's what we've been trying to do. We renovated Cox. The last time the Board of Commissioners felt like they couldn't do the expansion is when the recession was beginning. They did make a decision to do some renovation at Cox, so we renovated the existence. This is a really important point. There's 74,000 square feet in Cox that were renovated within the last 11. So we don't want to walk away from that as well, or the investment that we made there. That renovation cost $9 million, and in the DSS world, the federal and state government contributes about 30% of the total cost. There are requirements for space. You know, they clearly require for DSS, it's in administrative code, and contrary to what some people may say or what you may hear, administrative code is not a, you might want to think about doing this. It's a legal requirement, but just as law, it is in what a law would be on the criminal world. It's a requirement it's a requirement on the administrative side. This is because we think it's important for the public to know. There's nothing that sits at Cox counties aren't mandated to do in North Carolina. The space requirements for DSS that are set forward in those administrative code are there. That is something the state's looking at. We're encouraging them to look at. We don't know if it changes to smaller or larger because what we do know is that likely if and when it does change, they will make some distinction between staff who interact with the public and staff who don't. But the requirements in CFAS require dual monitors and scanners, so we don't know if it will increase or decrease. And the state is telling us they have not even begun that work, so it'll be far out in the future. Requires we provide parking for our consumers. It clearly says that the state may withhold your administrative revenues on the DSS side if you don't comply with space. That's $20 million for us this year at risk if we don't comply with space. I've had the question maybe they won't. I mean, clearly they don't want to shut down a county DSS. We are one of those counties who've actually received written correspondence from them about our lack of compliance. And I would point out, every law in the book says may. It says the judge may give you 1 year or they may give you 20 years, but I can't stand here as your director and tell you it's a $20 million risk I'd advise you to take. I also have to tell you, we can no longer be efficient in our work in our current structure. What we've tried to do is be very customer focused, that it's accessible and streamlined. We've really tried, this has been a county-wide strategy, to understand we cost people money when they have to come into the county for a service, so how can we do so as quickly and as efficiently as we can? Where you have public health and economic services together at Cox, because that's where we have the greatest crossover of consumers. You also have social work services located in a court annex. Again, one stop for consumers looking at where citizens can get dual services in one location. Jessica's staff in environmental health is located with permits and inspections. You know, if you ask people in the construction world whether they're building residential or commercial, they're very complimentary of the county process because it's one stop and saves them time and money and is more efficient. Child support is in the courthouse for that same reason. This is where our clients live and where their addresses are, and just make the point that 47% of the consumers we serve, their addresses fall within 5 miles of Cox. One of the issues that has come up is, could we be located somewhere else? We've done a pretty extensive property search, but want to make the point, state has to approve where we go, and it has to be central. We sit across from Asheville Transit. That's about as central as you can get. One of the issues, it's a legitimate issue, is do we harm downtown development if what we continue to grow downtown are government structures? I would just point out that the bus stop and the post office are our neighbors, and they're not going away. I can't turn that into a non-government corridor simply by moving. It is a government corridor. There's a lot of research that says if you want a strong downtown, government's a part of that. That's our current building. Beautiful is not. The other mapping that we did, because we think that this is very relevant when we looked at moving somewhere else, is who are the other services that our consumers access and how close is Cox to them. The average distance to these other service providers from Cox is 1.1 mile, and 67% of those other service providers are less than a mile from Cox. If we look at, if the decision was to move somewhere else, we would lose what we currently own. We lease space currently. We're and this shows you the cost. These are all the places, you can run back to that one real quick, that we currently lease parking, because a part of the redesign is the deck.
You don't own the spot that's right in front of the building?
We do own that one. That's 120 spaces. Because of other things that park there, but that's consumer access. But we still lease all of these spaces for our employees. That's about $130,000 a year in current lease. And I mention that because that's a cost offset as we move into a debt. So the decisions the county commissioners are weighing, and they have many difficult decisions to make. I don't want to minimize that in any way. Really set us up for how we move forward in the future and make sure that we do draw down optimal reimbursements and that we invest in a building understanding the intent is that it lasts us 30 to 45 years. One of the cost analysis that we've run is what would be the difference if we don't build and we move into leases. And we'd have to look at leasing everything because we're going to have to be co-located. We can't continue to operate as we are in the number of buildings we're operating in. The most conservative estimate of that is about $22 million, the difference. Costs more to lease long term. This shows you where we are, and the yellow shows you all of our current lease parking. These are campus possibilities, meaning the county is actually, with the owners of some of those properties having agreed, doing appraisals to look at it, should property acquisition be a part of this as well. This is an actual picture of the design. This is very much driven by city code. I would also make the point, this is the design we did the last 2 times. And if we go into and we are making some changes internally, but if we go into a mass redesign on either the deck or the building itself, it'd be very costly. That shows you, the old building remains primarily does not change. That shows you both the deck and then the tower for staff. Has to be long and narrow because of where we see it.
Where do you make up the parking that you've lost?
Where
Is that parking behind that?
this behind it, this is the tower into the parking deck. It's a 650 space deck. We park 440 employees there every day. And then you have to account for the consumers or public who visit. So we need to account for about 680 spaces a day. And in addition to that counts when staff are out for leave. I mean, we try to get as much out of that as we can.
And then if we do have Medicaid expansion and the numbers are bared out, what you had in your slide earlier, you just mentioned 30 extra staff people on there. So you have also a statute on mandating number of spaces for your clients within as well. So is that area enough for this anticipated growth?
We think it is enough. We do. We believe that the intent, and we're trying to build with that in mind, is that not on the public health side, but on the DSS side, that'll become more and more reliant on technology, and that technology will let us anticipate, or will know changes that happen in individual recipients' situations and be able to deal with more of those through technology or call center, and are building for that. What's different about this, and I want to make this point, is this would be the corridor of entrance, and what these are self-serve kiosks. So what we really want to move to is, if I'm here to make an application, I might do that online. If I'm here to drop off something that's required, like a pay stub, I can scan it and get a receipt and leave. I don't have to go to the check-in, to the front desk. We really are trying to make that whole front corridor self-service, and that's driven by we've piloted that at Cox with 2 kiosks, and this has 11 kiosks. We also piloted at Cox, because we didn't have any space, the kiosks sit in the main lobby if you've been in there. These sit in the walkway, but they are offering a little bit of a buffer. This is actually the design of the building, and I want to bring this up because what you see is, that's the deck behind us, what you see is we really are shrinking lobby space. We're not about people spending a lot of time in that lobby. We're about moving them to the appropriate wait area. The design of it does allow, which we have to do on the public health side, to expand that area and to have it have an easy flow through if we had to do some kind of mass inoculation in a public health situation. So it is designed that way. That's entrance and lobby the other way. Again, seeing the actual kiosks, self-serve scanners. These are all scanners, so clients can scan their own information. This is a redesign of the clinic, and to my knowledge, and somebody from the clinic, correct me if I'm wrong, it's the first time Health will ever operate in a clinic they got to design to be a clinic versus. Is that true? Look at Dr. Ballador. She's all about that. It's the very first time we've operated in something designed for anything but a clinic. This will be the first time we have the opportunity to do some redesign. That's the WIC space. We could just jump to it. And I bring this up because this is the second floor of the new build, the second floor, and all of the towers look just alike. And my point is, this is all about space for staff to sit, the required number of supervisors for those staff, a break room and restrooms. There's not anything, despite hearing a $48 million price tag, that makes it feel like it would be a very extravagant building. These are about cubicle space with the required ratio of supervisory offices, which under administrative code have to be private spaces. They all look just like that.
How many floors is it?
7. It's a 7. Yeah.
So every floor looks like that?
Every floor looks like that.
From the second floor.
And again, this is about the 30 staff, the required number of 37, I think, required number of supervisors, required break room, that's code, and restrooms, and that is it.
Manny, on the far right, is that the old building showing it connecting, or?
Yes.
It is, okay.
Yes,
And,
and
and they are gonna, it's gonna.
up to 2 it'll
Yeah,
connect.
okay.
And Philip's design has been that he is basically going to have staff who see public on the first floor and the second floor. And then the stacking towers will be eligibility staff who are processing eligibility determinations, but not necessarily interfacing with the public. Can we answer any other questions about it? You want to talk about what's in their talking points, Lisa, and kind of the role?
So one of the things we are going to try and do is help you guys with some communication talking points when it's appropriate. And so in your packet, both electronically and in front of you, you have a copy of the current draft. So I'd love for you guys to look through these and give me some feedback about what's good about these, what's not good about them. But try to just highlight some of the basic information that Mandy just went over, starting with really the increase in the caseload that we've had to deal with. You can see highlighted there like the percentage change in food assistance, 106% change, the number of people receiving food assistance. So it highlights those larger changes. I'd also highlight some of the things that we've done to try and maximize the space that we have, the fact that health staff have moved, some of them 14 times in the last 5 years, and just a weariness on staff's part from having to continually pick up, move, and some confusion on the public side about where people are located. The corridor of service is another important concept, we think, because of so many of those, 67% of those health and human services businesses being within a 1.1 mile radius of the current Cox location. It really does help that ease of access and referral for the clients that we're serving. And then one of the things that we didn't highlight in this PowerPoint, but I think is really important for people to remember, that every county dollar in health and human services has a return on investment of $9.30 in our community. So when we bring in that Medicaid money, when we bring in that food assistance money, that's money that's federal dollars that are turned around and then put back into our economy, our local economy, to the tune of $9.30. So it's not a bad investment. So does something like this work for you all in the way, if you're asked? We know some of you have had questions from the public, and so we wanted to make sure that you were armed with the kind of information that you could answer questions if you were asked.
So where exactly is the behavioral health urgent care center?
We're going to get, that's next.
Lisa,
That's part of this footprint.
It's actually a different one. Yep. So we're going to talk about that next. Yes.
I told you this was fine initially. What I would like, I think, would be projection of these areas. What are our projected food assistance in maybe 2020?
Okay.
Because obviously the building is going to handle more than what we're doing right now. So what is that? She had some of those projected numbers in there.
I'll be glad to
Perhaps
add them.
with Medicaid expansion, that would be helpful as well, because that says that we simply can't provide the service in the current facilities, period.
Right.
We have to do something.
Right.
But that growth is where we would have the opportunity to use the new facility.
That's great. We'll include that. You know, one of the things we focus a lot on economic services, but I think Dr. Mullendorf could also speak to the fact that you can't move in those exam rooms. I mean, it is very tight. I don't know if that makes it even tighter, Dr. Mullendorf, but it's pretty snug, isn't it? I mean, we focus a lot on the economic services side of it as well, but there is just no extra space anywhere. 2 people in those exam rooms is nearly impossible with a patient, right? Yeah. So anyway, so do you have questions about the addition, what it would mean for?
So this is, I'm sorry, I'm on a date on this. This has been taken to the Board of Commissioners already,
Yes.
and it's going to be a bond
What's on their agenda next is the approval of the financing.
for 48. How much?
48 million.
And just to get back to the previous question.
34 million county dollars.
Okay, just as John Q. Public, I'd look at this and say, okay, this is gonna meet needs through 2017, what about 2025? Do we have any sense of that if we just plot your lines and be able to tell the public where we're gonna be 10 years from
Yeah,
now?
he does.
That was my question.
Right.
What's the projection?
We think that, we will send you those projections, and we do think that it clearly will meet our needs for the investment we're making in the building, which the state would say somewhere, depending on how you finance it, between 25 and 40 years. We do believe that, but we believe that's dependent on NCFAS delivering what it's intended to deliver in the long term.
In the way of efficiency.
Yeah, that's right, in the way of efficiencies, and we're clearly not there yet. Now,
Are you implying by that you're still at a point where everybody just wants to blow up NCFAS?
we're beyond
You haven't
that.
gotten beyond that?
We're beyond that, but Angie may not be, as it's
Philip is
beginning
not
in
nodding
child
his head
welfare.
either way there.
I do think, I don't want to miss the point Lisa was making. We talk a lot about DSS in this building only because, two reasons. Is that's where we have the requirements for space. That's where we can draw down reimbursement. The reason for putting DSS staff in the newer part of the building is not because, despite what might be said at some points, that's my love versus public health. I love them equally. It's all about, we can draw down reimbursements of about 30% on the DSS side, and none of those apply on the health side. So it's just a simple business decision that we have the capacity to build new in the DSS world and to renovate in the public health world. Pure economics is the only reason. That and growth of economic services. And I know y'all have seen the statistic. It's on your PowerPoint. I mean, it's on your your talking points. 1 in 5 people in this county are on Medicaid food assistance, and that's not about just our economy. That's true. Y'all saw some of that with Tom Tavit's presentation last month. That's true nationally. That's the truth of it. And one of the questions that we heard at the zoning public hearing is, we don't want these people downtown. Well, these people are the people we all work with and go to church with and live in our neighborhoods and communities.
I wouldn't sweat that issue, Mandy. I'm okay with that. But the point about the projection on Medicaid expansion, I think a week or two ago on the radio, didn't the governor say, oh yes, well, we might consider it now?
Yes, we believe that.
So your expansion is
includes that.
Go to that 54,000 Medicaid recipients. And,
Yes.
and I remember just 5 years ago, you were saying it was going to be 25,000 additional for the county. Since that time, you've gone up 10,000. So you've gone halfway there without
That's right.
the Affordable Care Act Medicaid expansion.
That's right, just recession. We have very detailed information, which we're happy to send out the update to you all on part because of our data and part because of the FQHCs. We have really good information on who's out there who will be eligible under expansion, and for us that number we believe is about 11,800. There is savings for us in that expansion which gets lost. We churn those people now, and Philip's staff, every year when I have to go in and apply for my health insurance, if my income's a certain level, you get kicked to Philip's staff to determine Medicaid eligibility before you can purchase insurance in the marketplace. So we're doing that work on those 11,800 people now.
And it's worse than that because those dollars, federal dollars, are actually going to other states.
That's
that have
right.
expanded their Medicaid. And I would like for North Carolina just to have the money coming here. It'd be nice.
So, Mandy, I have a question that's a slightly different take on this. So, lots of design has been done, and it's, you know, it's there and it's great, and it's obviously going to be adaptable. You know, with the cubicle setting, you can do a lot with cubicles, you know, once things change. But have we benchmarked in preparation of this building, clinic space, DSS space, have we benchmarked against perhaps another community slightly managing a slightly larger volume than us, or the projected volume we anticipate, such that we have a sense of, so this is sort of what their flow looks like, or there's some other, you know, larger systems that kind of are seen as that cutting edge in the building and workflow process. Just having done a lot of moves over my career, and having a lot of space designed, you know, designing for this length of time is going to be, you know, challenging, and we should do it as well as we possibly can.
I would agree with you. We surveyed all of the DSSs, again, because that tends to be where the growth has been, who have built buildings in the last 5 years, Philip, 10, or are currently in design on renovations or building, and there were 15 of them. The only other urban in that mix is Durham, who is is about 100,000 larger than, not quite 100,000 anymore, larger than us, closer to about 70. Their economic service caseload pretty equal to ours. And we've used some of their design, but they have built a building that, you know, theirs is a $98 million building.
Beautiful building.
It's one of the most beautiful buildings. Mecklenburg built a renovation and commissioned the art in the building. So it's hard for me in my environment to feel like I can benchmark totally against those, but we have all, with those urbans, talked about what do we want, what does space need to look like from an efficiency standpoint. And for us, a big change is that self-serve part in the lobby, never having you connect with an employee if you don't need to, and then structuring our floors to people who interface with the public and those people who will never interface with the public. Some of what Philip's talking about, who does intake versus who processes ongoing eligibility. We've been asked about, why don't you just work 24 hours a day, hire shifts? We work staff in the economic service side from 5 a.m. in the morning until 9 at night. That's the only time the state system's up. It goes down at night because it has to do maintenance, do updates, transfer data to NCAC so physicians can see who's eligible. So it is not available to us from 9 at night to 5 in the morning.
We did look at on the public health side. Laura Pless, who's our practice manager, and Dr. Mullendor and Ellis actually looked at lots of different designs with the architect to make sure that they optimize the best design for the clinic space as well. And we actually, we lost some space, but we actually expanded space for the clinic to use the entire one side of that building. And so we tried to look at multiple areas to try to make sure that we were doing as much as we could to maximize and to plan for the future.
Without the commissioners actually technically having a voter approve this, but the projected duration of build, start to finish is?
Well, you know, it's on their agenda for Tuesday. If
You're
approved,
going to break ground Wednesday.
well, April 1st. You know, for us and people, I appreciate that question. It's not as easy as saying tomorrow we go into construction. We just still deal with 100,000 people coming in the front door. You know, in construction, we'll lose our front parking lot. We have to offset for that. We have to relocate the clinic because the new deck comes 2 feet into the current clinic. And you have to educate the public on where to go for these services. Now, you don't want somebody who has a serious infectious disease situation wandering around town trying to decide where is it I'm going for that clinic. So there's a lot of lead time for us, which we're have tried to be as prepared for as we can. When the commissioners get through the vote on Tuesday, I'll be sending a flurry of emails one way or the other, because if we don't get approval on the financing of this, we'll have to lease space. We can't operate like we are anymore. We're just out of options.
So one of the things that you all can do one way or the other, that kind of the ask for us today with regard to this, at some level is going to be communicating with the public, whether we're leasing space or whether we're going forward with a addition or we're having a lease space. We need to get the news out to the public about where services are. We know from the last time that we moved and had clinical services moved, and then had that at the same time that winches took over primary care, there was some confusion in the public, and we want to do a better job going forward this time to really make sure we get those key messages out. So as board members who happen to be representing organizations that support many of the same people that we see, it might be good if you wouldn't mind to help us get those messages out, whether it's on your website or brochures in your lobby. That would be really helpful to us. So.
And don't forget the elevator speeches.
Right.
When someone asks you, you should have learned enough from this to be able to do a 2 or 3 minute presentation. I learned something. I wasn't aware that there were regulations on space size that's dictated by statute. That's something that's really important. Now I know that. I also learned that technology is not going to automatically fix all of the problems we have. Technology is going to demand a different configuration of space. So there are a lot of these things that we can say in our conversations with the public that will help. Okay, I think we need to move on to the
Okay.
next one if we can.
Two other projects that we're involved in that you'll hear a lot about, including next month, how to engage the board around some of our work related to domestic violence specific to children that Angie will be leading next time, and doing some breakout with the board on how the board can be involved. The other commitment the county's made is to move forward with a family justice center. And a family justice center is actually an evidence-informed model that provides a comprehensive approach to dealing with victims of physical or sexual assault. These are the numbers, and y'all have seen this before. The blue are 911 calls for DV, and the little stars on top of them are Child Protective Service responses, many times to the same houses or same situations. Numbers are pretty staggering, and all over. We are not necessarily proud of the fact, but I think it has been one of the things that have motivated us. We tied for Wake in 2013 for the highest number of domestic violence homicides in the state. I will tell you one of the distinctions is that when the Attorney General's office puts this data out, they're talking any domestic homicide, whereas we're focused on intimate partner homicide. So if you lease a room to somebody, you would not show up in our statistics, but you would show up in the state's. This one's pretty staggering to me. That Helpmate sheltered 131 families last year, but they had to send 265 out of county. They simply didn't have the shelter space to serve them. Dr. Creighton took some national data on cost of domestic violence, and it got extrapolated on a state level. Then we did that on an actual county level, and the total cost, annual cost of domestic violence to our community is $6.7 million. You see the bulk of that sits in the physical health side, response from the health community related to that. We try to understand what happens for victims once an incident occurs. This map, I think, is motivation for this new initiative alone, but the first 3 days after a victimization, a survivor fills out 61 forms, travels 8 times, makes 5 phone calls, talks to 21 people, waits 12 times, gets 30 referrals for services, and some of them said they still weren't helped at the end of that. So what a family justice center does is put all of those resources in one safe, both physically safe and emotionally safe environment for survivors so they can access them. Important point is we talk about our Family Justice Center is in Buncombe. We're also including our Child Advocacy Center, and we'll talk a little bit more about that. But it utilizes evidence-based practices and delivers them in a coordinated or comprehensive way. So why a Family Justice Center for us is it's an opportune time to capitalize on the commissioners adopting a comprehensive domestic violence plan. Our community has talked about, our newly elected district attorney has been very focused on a child advocacy center, a more coordinated approach to how we address child physical and sexual victimization. The volume continues to increase, and we know that. We know that the current system creates additional stresses or traumas for victims. So how do we take that fragmented system and deliver it in a way that's supportive? We also know there are inefficiencies and that those are costly to our community. This is the national data on why family justice centers are successful models, and what you see is they've actually been proven to reduce homicide in those highest risk cases, increase the victim safety, reduce fear and anxiety for both the victims and the children, decrease child protective services intervention. If you can provide that wraparound service to the non-abusive parent, you can often prevent the need for child protective services, long-term intervention. Doing this kind of model will let us increase Helpmate's capacity for shelter, and it's more of our emphasis on one-stop services. Also improves the system efficiencies as a whole, and we'll talk more about that. These are all the things that will sit in our Family Justice Center exam rooms for both child and adults, and what that means is the Child Medical Examiner program, or Dr. Cindy Brown's program, which is a component of Chapel Hill, is available for North Carolina County Child Protective Services programs. These are forensically trained physicians and physician assistants who evaluate the presence of child abuse or neglect. And the same would be true on the adult side for the same nurses, or the sexual assault forensic nurses that are employed and currently working out of the emergency department at Mission. Interview rooms, therapy rooms, service, all of our partners, nonprofit partners, would have shared space for law enforcement and DSS, and we'll talk about the efficiencies gained for that as we move forward. These are, as y'all recall and you all saw, all of the elements of the domestic violence plan that the commissioners endorsed, and y'all have seen that before. I want to make the point that either through direct county commissioner allocations or by investments, performance-based contract investments that Health and Human Services have made, counties invest in almost $78,000 a year in supports to family violence. 35 Woodfin is the perfect place. And all of the partners immediately agreed to that. Mission and the county and all of our nonprofit partners did extensive research and extensive property searches about what's an optimal location. 35 Woodfin, optimal because it's so close to the courthouse and law enforcement, and because as we visited other family justice centers, there are great efficiencies gained when it's co-located with law enforcement, CPS, and APS. And Angie has about 200 staff who already sit in 35 Woodfin. What we're continuing to do is visit other family justice centers, and then we're meeting on a weekly basis with the leadership teams from all of our partners. We're attending the national conference and taking a large team, 30 people to the, is it 20? 20 people to the national conference in April. They're providing us, by joining that actual national organization, technical support and consultation, and we're actually we're, as I said, meeting weekly to move forward with the development of the Family Justice Center. Who'll sit there is the criminal investigations divisions for the Sheriff's Department, APD, and the DA will have space there. So they'll share space or be in the same part of the building with Angie's domestic violence social workers and forensic social workers. If you knew how many times in a day a forensic social worker at DSS and a detective are trying to connect by phone, those are field-based people. They don't sit in their office. They spend an inordinate amount of time trying to connect by phone, even though we share information electronically. I think we're probably the only county that does that. But the ability to sit together and process these cases in the joint investigations together has huge efficiencies. Helpmate will sit there. Our voice, which is the sexual assault equivalent of Helpmate, the child prevention services, and Fiscal Legal, because Fiscal helps many of these victims with protective orders and other legal processes. Mission is our partner in this, both of the two projects we're going to talk about. Their sexual abuse nurse examinations will occur there, as well as the child medical examination.
Can I hear?
Sure,
Okay,
absolutely.
So typically somebody's assault is brought in the emergency room, you're telling them to be transported up here for exams, is that what's going to happen?
Actually, they will be available here 24/7, and much like you'll hear on behavioral health, we'll begin to do training so that detectives bring them to this site first.
Okay.
Unless there is such an acuity of
Right.
that they need to go to the ED. Okay. So this will be the first stop, and there are a lot of reasons for that related to how victims perceive their emergency department experience.
And so law enforcement would be transporting them from the...
Or the helpmate advocate, depends who they made the connection with. Let's talk about the design though, because the design's pretty critical. What you see in yellow are the child advocacy pieces. So this, as you come from the parking deck over here today, where the playground sits, this will be a separate entrance to the Child Advocacy Center component of this. It includes therapists, includes exam rooms, includes interview rooms, office space, but these are by appointment, and they'll come in a door that will be made to look like a very friendly door, not a government building. This will be the only place that those consumers and their families circulate in the building. The technology being built in the building means that if Dr. Brown is interviewing a child sexual assault victim in one of these interview rooms, Angie and the detective and the DA are watching that via computers, feeding their questions to that one forensic interviewer. And that child who's currently undergoing at least 3, probably more like 5 interviews, will only be interviewed once. Those will all be tape recorded. Also, there are therapists in this section who are specifically trained to deal with trauma and trauma supports, and they'll, both on the child side and adult side, be available to support that victim and their family, not only through the examination and criminal investigation, but through the prosecution. If you come in the side that faces the deck, most of these individuals will come in the main entrance, but if this orange is primarily around the same nurses, and you can see their exam rooms, their shower rooms, their labs, all of those medical components. So their victims will enter with them through this second door, come into this secure corridor where the exam happens, the rape kit is done, all of those components are done, have the same capacity for an interview to occur. The detectives and social workers who are on this other corridor to watch that electronically and feed questions and only do a single interview. This corridor actually places Asheville Police Department, Sheriff's Department, Criminal Investigation, their specialized sections with Angie staff in one joint area. It provides drop-in space for the district attorney. They'll be over here part of the time, and also provides required evidence, ways to both process and store both physical evidence and electronic evidence related to these cases. Again, going to this side, the part that is white is HelpMate, primarily Fiscal Legal, the Child Advocacy Prevention Services Center are in these other components. What you see built in are therapy rooms, so they'll actually be able to access those services on site, and friendly dens. As we visited other sites, one of the things we've heard from both those sites and victims is that it is a safe, comfortable place to wait and be served. These adult victims or child victims won't have to go to the government side. As those interviews need to occur, will come to their side and occur in that safe environment. So a big shift in practice. That gives you a little more detail on the child side, so you see which Dr. Brown has been involved in designing the space, and this is one of the areas that Mission's partnering with us around. That gives you a little more detail about it. You don't, you really got to separate child victims and adult victims, because on this side of the house, you often think you have a supportive parent who later ends up being a suspect or an alleged perpetrator. So these are very separate parts and designed to be. And we are, Mission's been very active and has had a child and family safety coalition meeting for probably a couple of years around this, and they're continuing to provide support. This is the role that they have, is they're studying grant potentials, looking for potential grant supports, and helping work with the nonprofit side to make sure we have the rep network and sharing of information and coordination moving forward. And happy to answer questions. This one's really, really exciting.
And the projected cost of that build is?
We don't have all of that yet. We are applying for some grants, and Mission and the county are sharing in the cost of the renovation of it. But I'll bring you those as soon as we have them. We're still putting people in boxes. A lot of the cost is going to be technology. The ability to do those interviews and build that evidence capacity, more than the office space, which is already built, and then the exams rooms, building those specifically the way the same nurses would like for them to be built, and for Dr. Brown.
Well, those floors still have ceiling tiles on them, don't they? As far as Cat 5 tables concerned.
They do. They do, and I'll tell you, One of the biggest challenges, and we've not nailed it either in Angie's shop or the sheriff's news shop, is soundproofing. When you're doing those level of interviews, the soundproofing components, all of that's something we continue to struggle with. That's why I can't give you a total cost. What I understand about the cost is that I better be prepared to find it and cover it. I get that part, but I don't know what it is yet.
Andy,
I'm sorry.
Soundproof, have you, this is probably in the weeds, if it is, I apologize.
No, we've been living in the weeds.
Have you considered, pumping white noise into the air, because that, in our corporate facility we had, that was cubicles, it's amazing what you can do.
We've done that fairly successful in Angie's shop. The challenge is for law enforcement, when you're video or audio recording interviews, any white noise can raise issues on the defense side about what's that noise and are you muting and are you changing. There's nothing simple about this. I'll tell you what, we won't go back to floor plan. One of the biggest debates has been an extra restroom. They want those interview suspect rooms, and it's the other hallway. There's a restroom right behind them, which is, what if the suspect goes in the restroom and tries to listen to the interview? It's like the nuances of really building for this are kind of phenomenal.
The other thing about the white noise with child interviews is
they're
many
distracted
times when
by
children
their
are
own
disclosing, they'll put their head down or say it really softly. So if you really want to capture that, you can't have any interference.
The research says they say the important parts softly in that kind of setting. They tend to whisper. So I'm telling y'all, we're cutting edge with these. Any questions that we can answer? Lisa, you have talking points on that one?
We do. I have another page of talking points for you guys that again bullets out some of that key information, but certainly can add to this as well. I heard clearly what I need to do with the addition. So if you have other, I know we got one more slide presentation, which is fairly short. Are we good?
Yeah, this is the only agenda we have.
Okay.
Just a quick question, is the kind of national model, we're using the Family Justice Center Alliance, are they the parent, kind of the?
They're the parent.
Just because I was like looking, and so in North Carolina, the only other one on their webpage listed is in Alamance County.
Yes, and y'all have visited
We
or
were
got
visiting on
rescheduled because
Tuesday.
of snow.
We had to
Okay.
reschedule.
And there's one in Knoxville. I was just looking
We've
to
been
see.
to Knoxville a couple of times.
You know,
Ours is different in that we're including that child advocacy part.
yeah.
Mainly family justice centers are focused on the adult victims.
But you raised two good examples of why 35 Woodford. Alamance is within DSS, and Knoxville has very much this same setting, which is, they came back and described it as half the building is the bad government, half is the supportive deals. So that's the way we're designing this building. Except we're good government, but we can be perceived in that setting. There are a lot of nuances to that. A lot of domestic violence victims fear DSS and have been told, you know, if you disclose, DSS is going to take the kids. So there are a lot of nuances to making this a safe space for victims.
And we are working with a national organization, Safe and Together, to look at our child welfare practice. You know, our mandate's to make sure the child is safe, and it's in our best interest to make sure that victim is safe as well. So it's helping us to really look at our practice and hone that.
So Lisa, a good thing, I think, you know, I'll speak in a I statement. For me, what might additionally be useful are some of those references to kind of some of that national model stuff, just because that, one, it's interesting to me, but two, I think we do have, you know, community members who are interested to say, well, where are you getting that? Where are you coming up with this stuff? And is it really going to do what, you know, they're saying it's going to do? So it's always good to be able to benchmark back or say this is benchmarked against, you know, this great practice that's happening in these communities.
I think that's a great idea. Angie is going to talk next month. We really are doing drill down on just this kind of model and what role the board can have in some of it too around some of those things. But there's several working groups, including parent education, prevention. I mean, there are a lot of work groups around domestic violence. Some of them are court-related, law enforcement. Some of them are on the service side. So I think giving you those resources is easy to do.
Well, and I like seeing the health and the human services blended in terms of what Dr. Brown's group's gonna bring, you know, and the forensic nurses. I mean, really, that is, you know, it's integrated, and we've talked about, you know, we need to do this from the top down, and we need to also do it from the service provision as well, that those are integrated and providing that care in a unified way.
That's a very good point.
One of the things April Burgess said that really stuck with me, I probably should have put it out, one of the talking points, was that they find that women that come into these centers, they'll put them in the room, the waiting room, and they'll come back to get them and they're asleep. And it's because it's the first time they felt safe enough to be able to sleep, and it's, you know.
And I know, because we're going to deal with a lot of this detail as we go forward, but some of the capacity being built in this building and what we're working with the judges and the clerk on is, if I go into this building and Fiscal works with me on a protective order, I'll actually be able to dictate that into an electronic system. It'll generate the protective order that'll ding on the judge's desk or ding on the magistrate. They will interview me via the video, so I never walk in the courthouse. Research tells us that's where most of your homicides occur, is that trip back and forth to the courthouse. The judge will approve, based on the ability to see my injuries and interview me, the protective order. It'll electronically go out to law enforcement. The victim never leaves the safety of that deal. The other, also partnership, Smokey's a partner with us too, that we are currently working on with Mission and RHA Health. Dr. Weigel really drove one day after a meeting, talking to me about how we're really, how we continue to be challenged in the community to deal with behavioral health needs in the emergency department as the primary entry point. So we began working right after he raised that issue. A group of us began meeting and talking through how might that be different. What we know are those are currently very siloed, and you should jump in and correct me, but I'm gonna tell you we discovered some staggering statistics in all of this, including Mission ED seeing 445 patients with complex behavioral health needs monthly. I mean, it really is driving the ED, and that, you jump in.
I was going to say it's up from probably about 300 a month as recently as 2 to 3 years ago. So nearly a 50% increase over that time. 200
of them at involuntary commitment levels. You're talking significant levels of acuity. That's how many drop-offs law enforcement is doing, 172 a month. And then those are the services that RHA provides, but they've been very fragmented, and we really have not had a strong model for delivering peer support at the moment of the crisis. So that's a lot of what we're designing for. What we know, and Mission shares openly, is that their ED can be so overcrowded that those acutely ill patient wait days for access to psychiatric services. Some of the interesting conversations we've had are people in the community who've also approached us and talk about, I took my child to the ED who related to asthma, whatever, and sitting next to somebody who may be in a fairly acute behavioral health state of need, and how it's not helpful to anybody. It's just not the best structure. Dr. Polly shared with us the number of violent incidents in the ED related to this population, and they're significant. I don't know if you want to share any more specifics about any of that, but.
Well, I mean, I think, we've had a massive decrease in the availability of state services, state hospital beds. There's been a lot of talk about how we lost about a third of our Broughton State Hospital beds over the last several years. But really, if you go back 20 years, we went from about 1,000 beds to around 200 beds. And so all these patients that used to be served by the state system are in the community, and as the local system broke down more, they're coming to our ED. And you see it in the ED, and you see it hospital-wide. I mean, altercations, assaults in the hospital overall have gone up quite a bit over the last few years, and it's still other symptoms of the breakdown of the system. And so, yeah, that was sort of the driving force of something like this, which is you had multiple different arms of the behavioral health system through RHA, through Smokey, through Mission and others, and basically trying to get everybody on the same table, everybody take group ownership of the problem, and then you showed how it had been siloed, trying to bring it under one roof.
That's a coverage of the whole next slide.
Well said.
I love that. He should be doing it all. It was his brainchild. How do you take all those components and have a single door? And for us, the opportunity to do that at 356 Biltmore, the old Western Highlands Blue Ridge, depending on how long you've been around, was a great opportunity because we own that building, and most of the public or consumers identify that with behavioral health. These are, again, average number of patients waiting for psychiatric inpatient beds. And this one, which Mission helped us with, shows the increase in the acuity of the individuals presenting at the emergency department. Children and adolescents, the admissions over a 12-month period related to behavioral health. And this is that we're seeing the exact same trending, which Dr. White also knows, in the jail. So what we're trying to do is look at our current investments and how do we realign those to provide a more coordinated approach. So what will happen at 356 Biltmore is you'll have 24/7, 365-day access to a behavioral health urgent care center. It will be the place of first drop-off for walk-ins, paramedics, law enforcement. We will be adding 16 facility-based crisis beds for children. We'll keep the 16 crisis beds we have for adults so that they'll move across the street. That is not a point of agreement among everybody. We would like to increase those adult beds. We have significant need to increase those adult beds. State reimbursement system just makes that very challenging financially. There are no reimbursements for adults in terms of crisis stabilization beds. Really talking 100% local money to do that. Building that peer respite support, a living room model to provide support to the individual and their families. All of RHA's outpatient services will move there, and ABCCM will run a community pharmacy there. That access to both, Mission is providing the clinical 24/7 access on the medical side and RHA on the behavioral health clinical side. Those are the things that we believe will serve people more appropriately. It'll end up being less costly and we'll have better outcomes. This is the actual design of the building, which moves what is currently here over to this building. You'll have law enforcement drop-off, mobile crisis, recliners, and we'll talk about those, walk-in intervention for people off the street, peer support-led living room model, a nice comfortable environment to wait. These beds that are across the street at 283 will transition to 16 children's crisis stabilization beds, so that's added capacity. These are all the partners. Partners meaning financially and in terms of programming. Y'all know why we need it. The other new piece for us, which is something Gaston and New Hanover have, we've been watching their data for a couple of years, and it tends to be, it's pretty staggering the number of individuals you can stabilize within 23 hours. If you can address the immediate crisis, stabilize their medication, have them leave with both an appointment with an outpatient clinician, possibly wraparound community support, and the actual medication they need. They show as many as 90% of those individuals can safely leave in 23 hours and have the supports they need. So it'll add 6 to 8 recliners to allow that opportunity to stabilize their medication and wrap the services they need around. ABCC Pharmacy will be located in there, and what ABCCM will do is for the un- and underinsured, they'll one, refer them to a safety net provider long term, but they'll consult with a clinician on site about medication needs. They'll do medication adherence education for the consumer, and they'll actually leave with their medication. They won't walk out of there without it. The National Alliance on Mental Illness model supports all the components of this program, which has driven a lot of the design. This is the increase the capacity related to that. We do No, and I want to be honest about that. We had, and you should speak to that. We have greater need on the adult side than we're going to address with this. We just cannot, and have tried to run cost models, figure out a way to do that. There is some hope about some changes on the state level in service definitions that would offer us some reimbursement. This is also a population. Medicaid expansion would have a huge impact on. And that's it. We're happy to answer questions related. Those are three you're going to hear a lot about over the next year. They're kind of driving our world.
So that holding unit at, the old St. Joe's ER, that's going to become here.
No, we'll still have, you're talking about the PEA?
Yeah.
We'll still have the PEA, because we're, just what Mandy was saying at the end, for the behavioral health population we're seeing in the ED, this really is not increasing capacity for the adults immediately, so we're going to be still pretty backed up utilizing that holding area. We're going to create a new center for children, and that will decrease some of the volume in the ED, but until that number goes up from 16, we're still going to be.
But aren't you saying that when the law enforcement transports people
Yeah, they'll come here first.
they're
They're
gonna
at
go
your
here
point of
first?
first drop-off.
That's right.
Okay. So, I mean,
It
that'll
may
still
be
gonna
it
require
stops the-
professional staff to evaluate those people, but that's not gonna be going through the ED itself, though. For the
Right,
most
well,
part.
and right now, I mean, they're already taking a lot of those patients to Neil Dobbins. Like, Neil Dobbins is the current crisis unit,
Right.
and it runs at over 90% capacity virtually all the time, and they're already getting a lot of these drop-offs.
The NAMI and the consumer group believe that more individuals will walk into this kind of environment than would individually walk in if you're not under an involuntary commitment, maybe to the ED. And then the other component we hope will have an impact is if you go to Dobbins now, but you're not placed in one of the crisis beds, that's the only alternative available to you. Whereas in this building, we can offer you access to outpatient, your medications, stabilize your medications, have you leave with an assignment through our HA.
Well, correct me, I thought Dominus was more about detoxification, but.
It's half and half.
It's half and half.
Right.
Yeah, it's technically 8 beds, crisis 8 beds, detox, and they flex about 2 in either direction, depending on who's coming in.
And outside of Medicaid, there is no reimbursement for either of those services for adults.
I mean, for adults, I'd say, I mean, my expectation or my curiosity is the biggest impact might be those recliners, because we have so many people who come to the ED because they lost their medications or they missed their appointment and now they don't have a provider, and having one place where they can go to and walk out from appointment and prescriptions, that'll have some impact on the ED volume.
Right.
When do you anticipate this service being?
They're all very much dominoed, so we believe we can move our assessment center, which will stop running here in July. Then we'll begin renovating that space for Register of Deeds, and then we'll begin, when they move, the renovations. So some of this will open July 1. It'll become the drop-off place July 1. The 16 crisis beds in 356 won't be built out probably till the next January. But there's no loss there because we'll leave the 16 up where they are until these are built. Other questions? It's a great example of where a board member brings expertise on a subject and pushes about a need, and it helps us know it's there and mobilize it. So thank you for doing that. I know it's not everything.
I would say thank you. I mean, it's impressive that bringing that up started this process, and you and the county and everyone has stepped up in such an impressive way. It's really wonderful to see.
So this will get some press and.
It will. We're actually scheduling a joint, more of what Lisa calls a media invite-in, where Smoky Mission and the county and RHA will invite media in, and board may want to participate in that and answer their questions at once.
March 5th.
March 5th.
There was something, was it in the paper, or was it on the Mission Health Facebook page? I was trying to remember where
I
I
think
saw
it's
the
hit the
announcement.
paper because
Okay.
we sold a property and are using part of the proceeds for Mission and the county are splitting the renovation costs, which are $1.5 million. Am I right about that? Well, $1.5 million to 2 in a week is about the story of my world now, but $2 million. And then we're all three, RHA, the county, Mission, and Smokey will make ongoing contributions annually to the operating because you can't break even on service definitions.
Mandy, wasn't that 800?
That's right.
7,000?
Yeah. You get credit for that in the meeting where you said, are there properties we can sell and do better things with them? And we sold Chestnut and are dedicating that money to this process, which was, that really is what gave us that springboard in terms of funding.
So one of the things I realized in the key points I didn't put in there was the increased capacity number, so I'll add that to that. I think that'll be good for you, and then I'll add any references we have specific to why this model, again, is one of the better models. The same with the Family Justice Center. We'll get those projections on need versus building space. Other than that, was there anything else that people felt like we should have had?
We have the ones New Hanover and Gaston have seen around the recliners, so we can give you those statistics about, it's high, that number, but Rich has those.
And I would like to say, just knowing the medication access needs and challenges of this patient population, having the ability to walk out with medications in hand is incredible, because these folks would generally have a 3 to 4 stops to get everything they need put together. That is not a small, don't overlook that. That's tremendous when a lot of times to keep people healthy and manage, the medication access is just a key component with that.
And RHA has really made the point for them, the ability to sit in the same building with the pharmacist and have conversations about how all that fits in the overall intervention for them is huge. They're very excited about that.
So one of the key kind of messages for really all three of these projects in some ways is that by co-locating services in ways that create better coordinated efforts toward managing the outcomes that we're driving towards is really a better model. It's cost efficient, but it also allows for better outcomes. So that's another thing as we go further along, we can look at some of that return on investment from ED diversion and things like that. Rich has been really good at being able to cost those things out. So, but these kinds of coordinated care models are really good as far as, again, improving outcomes, but also being more cost efficient. So.
Anytime most all of these are examples where we're already providing funding, it's just realigning it in a more coordinated way.
You're gonna get more bang for your buck.
Yeah, there you go. That's an easier way to say it, isn't it?
And this one, both of them have planning teams that are doing detailed work. So if there's any particular interest in sitting on any of those, we can put you on the distribution list.
Thank you so very, very much. Those are very exciting.
Did you want to say something? I'm sorry.
That's okay.
The chair can't see you.
From the other presentation that was earlier this week, with you, the ACE.
Oh, that's right. That was a great presentation. ACEs, Adverse Childhood Experiences.
So one of the things from going to that and coming in here, that comes to my mind. So what you're doing is you're taking and reducing stress.
That's exactly right.
Going from the toxic stress they talk about to more of a tolerable stress. And when you do that, we've yet to measure the effect that that'll have on the population as well as costs within the county and the family. So when you reduce, anything, I mentioned it when I was talking about price of gas, how much that reduces, gas coming down, reduces stress in households of, people that are struggling. Anything that we can do to bring the stress level down in all of those things is, I think, would be very positive for the county in a human way and also
Dr. Weigel can tell Dr. Coopy, you got that out of that presentation about going from toxic stress to tolerable stress for victims. They presented that to all of our judges were there and all of our law enforcement leadership, and it was just astounding to see.
We got that presentation about 3 months ago.
Yeah.
So
we're actually Wednesday at the DV meeting going to walk through the Family Justice Center from the lens of are we moving from toxic to tolerable stress in the design and the process, if any of you want to be a part of it? Thank you. That's our
Thank
whole
you.
presentation, and clearly director's report too, and I think it's one.
Well, I'm gonna do this.
You do it.
I'm gonna do this anyway because one of the things that I wanted to do in the board is to really get to know people who are sitting around this table. I realize that I know faces, but I don't know much about people because we don't have a chance to interact. So I had asked 2 people today to start that process off. It'll take just about 3 minutes apiece, so we may go over just a little bit. But I asked Dr. Oliver and Ms. West to introduce themselves to this board. So I'll turn it over to Richard.
Hey everybody, I'm Richard Oliver. I'm your veterinary representative on the board, one of 11 professionals that by statute have to sit here. I began in 2002 by finishing an appointment by a veterinarian who couldn't make it, and I'm reading from the first minutes of the first meeting I attended. It said, following intros, first item on the agenda was presentation, followed by, quote, a lengthy Q&A, followed by a motion which passed with a vote of 8 in favor and 1 opposed.
Is that you?
I was it. It was an animal health issue. And I've notably resisted other motions and changes in the past, all of which I pretty much now support, to include board consolidation and primary care transition, and you remember those. Prior service includes vice chair and chair of the Board of Health during some very interesting times. Health Director Steering Committee, Search Committee, Community Health Assessment Steering Committee, Public Health Foundation, and twice I've been on the Health Department accreditation review team for meeting with the accreditation team. Currently on the Executive Committee and Public Health Advisory Committee. My perspectives and interests include rabies and other zoonotic diseases and animal issues by virtue of default. My passions, once again by default, are animal issues, underrepresented populations, how they cope with transportation, communication of their needs, and how they perceive us as meeting their needs, and what's available to them. And then 2 more, public education, and then I was talking with Jim and Commissioner Belcher. As I've been with it over the course of time, the stewardship is a big concern. Background and personal information. Born and raised in Eastern North Carolina. The year 1962 was seminal in my life because my family moved into a house out in the country. On Sundays, my dad said, we go look at the house. It's really boring. In the summer of '62, he brought me to Asheville. And he said, we're going to go look at this guy's house. I'm like, you got to be kidding. So he's driving up this long drive, and I said, what is this? And he said, it's the driveway to the Biltmore house. And I'm like, oh, wow. I fell in love with Asheville. A couple of weeks later, I'm out in the field playing. Car comes around a turn, hits my dog. Me and my dog screaming, we run home. My dad says, we'll have to take him to a veterinarian. And I said, what's a veterinarian? He said, it's like a doctor except for animals. And I said, oh, wow. So
That was the beginning.
now I'm a veterinarian in Asheville, and it all happened, can trace it back to summer of '62. Thank you.
Thank you, Richard. That was a very interesting. I learned a lot about you that I didn't know, and that helps me understand your passions. Thank you. Sharon?
Okay, so I'm Sharon West, and I am a community representative on the board here, and I've worked in public health for many, many years prior to my recent experience at the VA, Veterans Administration. I am a registered nurse, have been a registered nurse for over 34 years. And my perspective on this committee is that my focus at this point in time is on health equity, but also on women veterans' health and veterans as a whole. I love the population that I work with now, and right out of nursing school in 1979, I started working at the VA in Asheville. Here, Asheville's my home. And then I transferred from Asheville VA to Durham VA, and worked in Durham, and then I moved into critical care at Duke University and worked at Duke Medical Center, and then ventured into home health, which led me into public health, and I found my niche there in home care, health and human services eventually, because I love working with people in underserved populations. My other interest is intimate partner violence, and we're having some good things happening now at the VA and getting some things going at the VA as far as intimate partner violence and domestic violence, as well as a national initiative, a directive that's coming down concerning that. So we're real glad to implement that, but also work with the community on that as well. Passion in health and human services, I said, is women, veterans, health care, and my veterans, and health equity, the underserved populations, and I've done a lot of work in community with African American communities and getting health education to them, and various roles in the community to make sure that people are educated, people can make informed decisions, have a special interest in clinical ethics, so I do a lot of work in ethics and education and ethics as well. Just recently received certification from Wake Forest University in clinical ethics, and working on my doctorate currently in clinical ethics. So let's see, health and human services, gosh, I go back a ways. I was interim health director before Gibby came on board, and loved that, and learned so much in that role, and it was an awesome experience. I was clinical services administrator. I think I was on a public health board, I believe. I think I served on the public health board, and director of nursing. Also at the health department, Department of Health. And then currently I am on the social work advisory committee with Miss awesome Angie over there. And my background is, Asheville's my home. I was born in Brooklyn, New York, but we moved here when I was very little, probably about 4 years old, so Asheville's my home. So I was raised here, and went to nursing school at Winston-Salem State University, historically black university. Received my master's from Western Carolina University, and then the certification in Wake Forest, and currently doctorate from Albany, Medical College of Albany. So that's all I got.
Wow. And she's also executive, she's also chair of the board at the YMI
Yes,
Cultural
I
Center.
am.
That's
I am.
another thing that Well, thank you both for doing that. And I've already, I mean, this has really taken off. Dr. McLean has agreed to do, introduce himself in March, and Wendy Ziegler will introduce herself in March. So, and then we'll just take a couple at each meeting, and hopefully we'll get to know each other a little better, and apart from just sitting around this table. I want to thank the staff for being here today, and as always, we welcome you, and we hope that this is beneficial to you. We want to be supportive to you in the excellent work that you do. I know a couple of you are back here. And I'm also appreciative of the commissioners who attend outside your line of duty. Welcome, and we're grateful to have you here. Are there any other items of business? If not, I move,
Second.
I did it.